So hi everyone, you might remember I came last year and was quite pregnant and not so much anymore. So I've left the baby off playing in the playground with his dad and would like to talk to you guys about medications and CMT. And the reason I'm doing this year rather than talking about the research that we've been doing is it occurred to me during the question and answer session last year that this was a topic that was of the Society's interest. So I contacted Daryl and said, hey, would you be interested in me doing something next year? And he said, yes, please, please, please. And so what I'd like to give you is a bit of an overview about how medications work and what's actually known about medications and Charcot-Marie-Tooth disease. So I'm not talking about medications for treating the disease, I'm talking about the other things that you're on. Your cardiovascular medications, your lipid medications, maybe your diabetes medications, all of those other things, even your headache medications. So I'm going to have to do a little bit of science. I'm in teaching mode now. I normally teach pharmacy students, so today you can pretend you're going to be pharmacists. Pharmacology is the area of science that looks at how substances interact with living systems through chemical mechanisms. So how is that drug going into your body having some kind of effect to change some kind of physiology? If you're a person with asthma, how is that Ventolin going into your lungs and interacting with that lung environment to now make you breathe more easily? Ideally, it would be nice to directly deliver the drug to the place of need. Now that's not so bad for lung function, where we can actually inhale the medication, but what if you've got foot pain? What are we going to do? Well, you might use something like acupuncture. That wouldn't be a medication, that could be a useful therapy, but we don't normally take our pain medication and inject it into our heel. How does it normally get there? Normally it gets there orally, and it's able to go into our body and interact with those nervous conduction systems to decrease that pain that we're experiencing from that remote period of remote part of the body. Now there are all sorts of drug targets, and we call them regulatory molecules, and generally these are normal targets in the body that have a normal function. So maybe it's a pain receptor that's in the brain that's being triggered by a nervous conduction coming up from your foot to say something hurts. The only difference to that would be if we had some kind of infective agent like a bacteria, where that medication might be trying to affect the bacterial organism instead. Now, slightly silly picture, but as I said, we don't normally stick things into our foot. We might use something like a Voltaren gel rub or something that might provide some symptomatic relief, but most of the medications we take orally. So what's really happening to them? They're going down into your gullet, into your gut, and then they need to travel throughout your bloodstream to reach the pain receptor, in this case in your foot, to have some kind of effect. What happens along the way? A whole lot of things. There's probably a lot of you that are on, or many of you who are on medications for decreasing acid in the stomach. You might be on what's called a proton pump inhibitor. Well, what's in the stomach? This acid environment. Not all medications are going to survive through an acid environment. A bunch of it is going to go straight across the liver, and the liver is really good at decreasing the amount of medications that we have floating around in our body. And so in the end, while we might have taken a whole tablet, the amount of drug that actually ultimately ends up at that pain receptor is quite a small amount. So there are very many steps along that process that can alter the way that the medication is effectively reaching our target molecule. And we call these steps pharmacokinetics and pharmacodynamics. The pharmacokinetics is that process of time through the body where it's reaching concentration in the bloodstream and then is being removed from the body. And the pharmacodynamics is the bit where it's actually interacting with that target molecule to have effect. And we've got silly names for it that I'll come back to. But if we think about what we're after some kind of linear response where a molecule of drug is binding onto a molecule of target and having some kind of effect. Now, this is great. We're all different. We all have different body compositions and everything else. And so depending on the number of targets that we have and the amount of drug we take is going to depend on the effect that we might see. So what we hope for is this one-to-one relationship. What we might get is actually less than that. And that would be called a change in pharmacodynamics. And this may be due to a disease state, or it may be due to just getting old. So that's one area of sort of difference in drug activity. Another area is in this pharmacokinetics realm. So how the drug gets into the body to start with, absorption, how it gets distributed throughout the bloodstream, and then how it's metabolised and excreted. And this is our elimination phase. And really, this last two, M and E, is the main area that we would expect to see variation. You don't need to understand all the ins and outs of this graph, but what this is showing us is a time period along the bottom and drug effect on the side here. And this would be related to concentration in the bloodstream. So we take our tablet, it gets absorbed into our bloodstream, we see the concentration going up in the bloodstream, it reaches some kind of peak effect, and then our body gets rid of it. And we want this to happen because we don't want to start straying off into a concentration where it's going to be toxic to us. And it's very important that our body gets rid of medications so that we don't get into ranges of toxicity. And we call this a therapeutic window. So I mentioned before that the first thing that needs to happen is absorption and distribution. It moves from the site of application, whether that's in the mouth or whether it's a site on the skin that you've put some kind of gel, into the bloodstream, it gets distributed throughout the body in the bloodstream, and finally reaches its target. One of the ways that it does that is by what's called passive diffusion and equilibrium. And if you cast your minds back to early high school chemistry, you've probably done experiments where you put dye into a glass of water and watched it go from being a really concentrated colour to a very light colour in that glass. And what's happening is those little drug molecules are distributing through that volume to become even. And we want it to be an even concentration, or the body wants it to be an even concentration between the gut cells and the blood cells. Lots of things can change this absorption process, particularly if you are taking things orally. If you've got diarrhoea, for example, your gut motility is going to move through your gut more quickly. Sometimes if you've just eaten or drunk, it will change the way that your body is processing and absorbing those medications. So these are all just normal. They've got nothing to do whether you've got CMT or not, just normal physiology. Where it's administered in the body is also going to have a changing impact. If it's something that's administered into a vein, then we would expect the distribution to be quite quick because we're rapidly reaching the circulatory system. If we take something orally, the first place it will go is the liver. And I keep on coming back to the liver because it's really important, but the liver will actually strip out a bunch of that drug before it reaches the distribution and circulation. This process in the liver is called metabolism, not to be confused with other ways that we talk about metabolism. Liver metabolism is specifically targeted towards removing toxic chemicals from the body. We have something called a first pass effect that's talking about that first pass through the liver that oral medications have. Why does this happen? Because drugs in their parent form really want to actually stay in the body. And what happens with these metabolic processes is there are suites of enzymes that are involved in the liver that are able to chemically change drugs and chemicals that we're exposed to make them more readily able to pass into the kidneys to be passed out in the urine. So there's another organ that's really important. The liver's really important. If the liver's not doing its function, drugs can reach toxic levels. And if the kidneys are not doing their function as well, then we're unable to get rid of those wastes in the urine. And this is the picture from the inside of the kidney. So here's a slice in half of a kidney, and if you've ever eaten kidneys or cooked with kidneys, you will have seen the nice little dark brown organs that sort of look like giant jelly bean. You cut them in half. They've got all this rich red bloody filled vasculature in the middle. And if you zoom in even further, you've got these funny little things called glomeruli, and inside of glomeruli, and this is getting down to electron micrograph level, basically what you've got is a sieve. So you can see these funny little things, and this is quite relevant in a completely unrelated but trivial pursuit kind of way. These funny little things that are sticking up here are called podocytes, which are foot processes. They look like little feet. So there's just a random piece of information for you. But what these podocytes are doing is they're stopping all of the good things that are in your bloodstream, like your red blood cells, from leaking out into your kidneys. And all of the waste products are able to filter through these tiny little pores to go into your urine and be urinated and excreted from the body. So if you have kidney disease and this process is broken down, then it's much harder for you to be appropriately getting rid of those wastes. And certainly if you ever see any blood in your bloodstream, just get to the doctor, because that's a really big problem. So that brings me to CMT and medications and the evidence around whether things are okay or whether they're not okay for an individual that has Charcot-Marie tooth disease. There could be some dynamic changes due to disease state, but there's really not any good evidence for that. There's a lot more evidence to suggest that if you don't have a healthy heart, if you have liver and kidney problems, that you're at risk of some of these changes. There's a little bit of work around distribution changes that I'd like to show you. But the biggest area that you should be looking out for are medications that are known to have muscular side effects, like rhabdomyolysis or just myopathies. And that makes sense. If you've already got weak muscles, you probably want to avoid drugs that are going to make them even weaker. And you also probably want to avoid drugs that are known neurotoxins as well. But what actually is the evidence around all of this? And I thought, oh, this should be a piece of cake. I'll go and have a look in the literature. Should be able to find these lists. There are lists on the American Association of drugs that you shouldn't, or mostly that you shouldn't use. What is the evidence behind those lists? Is there any evidence behind those lists? And the answer is, well, actually, there's not very much. So why? Well, we know that the Charcot-Marie tooth disease is 1 in 2,500. It's relatively small. It's relatively common, but the individual subforms are relatively small, unless you're one of the common ones. And a lot of research just hasn't been done in this area. I did find one very nice review article that looked at medications that can cause worsening of disease. And what they concluded is that in 22 out of 26 published reports in the literature of studies that have been done, that there seems to be a problem with vincristine for people having Charcot-Marie tooth. And there are another 4 drugs out of these studies that are also cancer related. Now this is an interesting question. You've got cancer, you need to treat the cancer, but it might cause you to have worsened CMT. This ends up being a risk management decision with your doctor, because probably you don't want to die of cancer. You don't want to have worse CMT either, but what's the better of the two? The other thing that this study did is that there is a database, and Josh talked about these big databases that are around. There's a North American database of CMT patients. And these authors went in and interrogated that database, and they found 996 drug entries from 209 people that represented 190 families. And in that data, there were self-reports of people saying, oh, hey, I've taken this drug and I think it made my neuropathy worse. And they were able to identify in that 19 drugs that were in this situation. And so this is just a list of those drugs from that particular table. And just as an example, here are 2 antibiotics that they found on that list. And the report was that there were 23% of people who'd taken these drugs who'd experienced some kind of problem. Now there's another interesting problem with this data, and you have to look at the numbers. They only identified 13 individuals who actually took this medication. And then they only identified 2 or 3 out of those little groups that had a worsening neuropathy. We wouldn't consider that to be particularly strong evidence. If we go and have a look a little bit further, you can see nitrous oxide was another one. Wow, 50% of the people had a worsening of neuropathies. 3 out of 6 people. That's not very strong evidence in general terms. It's terrible for those people, and I don't want to belittle those people that had those experiences, but in the world of scientific research, they are very small numbers. Another interesting one, and statins came up last year, people were talking about statins. 10%, 2 out of 20, in this database suggested that they'd taken statins and experienced worsening neuropathy. But actually, if you go into the literature, what you notice is that 1.4 out of 20 people in a normal population who don't have any kind of underlying peripheral neuropathy experience some kind of muscle weakness. So probably this wasn't a Charcot-Marie-Tooth problem, probably this was just a population problem that was being seen in this group. So, with the exception of vincristine, the sorts of things that are on this list are not necessarily going to be worse for you just because you have Charcot-Marie-Tooth. And it's just something I want you to make sure you've got in the back of your head when you're talking to your doctor about these things. Now, I wanted to come back to this idea of distribution and some studies that might show some evidence towards some of these changes, because we're always after making sure that if we're going to make recommendations, that there is actually some evidence. So I want you to focus on this big blue middle bit. And remember, I had these little blue bits before where we were looking at drug moving in and out of different compartments. And we think about our body as being, in terms of drug distribution, as being just one big sack of stuff. One big bloodstream, one big sack of stuff. We talk about volumes of distribution. And these volumes of distribution are completely arbitrary. So you can have a drug that has a volume of distribution of 400 litres, not 400 litres. So if you ever come across these sorts of numbers, don't get confused between weights and these sorts of things. But we do have this central compartment and we talk about a volume of distribution. We know from ageing data that old people lose muscle mass, and therefore their volume of distribution becomes smaller over time. So it would be reasonable to think that in somebody who's lost significant muscle tone in their lower limbs, that they might have a decreased volume of distribution. What's going to happen in that case? Well, rather than having drug distributed all the way throughout the body, it's going to be more concentrated in a smaller volume. Is that a problem? Well, most drugs probably not. Something like digoxin, which is a cardiovascular medication, has a very sensitive therapeutic index. And so if you make it more highly concentrated, there's a chance that you might reach into that toxicity range. So digoxin was one of my targets for thinking about this. No problem, I should be able to find something with Charcot-Marie-Tooth. Not a problem. Well, I could hardly find anything about anything with digoxin. What I could find was a Japanese paper from 1987 in Duchenne's muscular dystrophy that suggested that the volume of distribution was significantly lower in patients. But what happened in these patients is actually, although the volume was different, they just actually eliminated the drug more quickly. So there was absolutely no evidence of toxicity. So this wasn't really supporting my theory that maybe if you've got muscle wasting, you might have a problem. It was very hard to read this paper. Luckily, the abstract was in English. This is a table that just shows you a relative indication of how different parameters might influence your pharmacokinetics, your ability to process and eliminate drugs. And remember, the reason we want to make sure that we're eliminating drugs is that we're not getting into that toxic level. Here we have it for young adults and here we have it for the elderly. Even without reading the names, what should strike you is that getting old increases your chances of toxicity. If you have liver disease, you're going to be at increased risk of toxicity. If you have renal or cardiac disease, you're going to be at increased risk of toxicity. If you take lots and lots of different medications, there's a chance that you're going to be at increased risk of toxicity. And we were just talking about this at morning tea. If you have a genetic background, it could lead you, a particular genetic background, it could lead you to having increased risk of toxicity. So where does that leave us if you're a person with CMT who's worried about medications? Well, there's lots of places to get information, and you should certainly be having that dialogue with your doctor. One of the things that's really important to know, or really important to discuss with your doctor, is if you're on multiple medications. And don't think about medications just as stuff I get from the pharmacist with a prescription. Think about it in terms of things you might buy at the supermarket. Those paracetamol tablets, your Voltaren rubs, your vitamins, your herbal supplements. These are all worthwhile things to take, but you need to make sure that your health practitioner knows about all of the things that you're on to ensure that you're not ending up with those interactions. It's perfectly reasonable to ask your doctor, does this drug have known side effects that can impact on muscle or the nerves? And if so, is there an alternative medication that I can take? Because often there's not just one drug that can treat one condition. If you've got high cholesterol, there's not just one family of drugs that are able to treat that. There are multiple families. And it may be that the doctor can put you on a second-line treatment that wouldn't normally be used as the first-line treatment, because normally it would be okay for an individual, any individual. Once you've got that prescription, if your GP is just really not kind of listening to you, you can always take your script, look up the medication name before you go to the pharmacist and check it out yourself. And I'll show you some resources to do that. And your pharmacist is a really good place to also discuss these sorts of things. And they're not scared to ring up your doctor and say, hey, you idiot, this person's got a nerve problem and maybe you should think about another medication. Of course, they're not going to speak to them like that. They'll be very, very polite about it, but they can certainly be your medications advocate. So, I wanted to point you in the direction of NPS website, and this is a really nice independent resource that's available, Australian resource, and let me just remind you that as much as possible you should use Australian resources. American resources are excellent, but they're targeted to an American audience, and there are some differences. Anyway, nps.org.au is excellent. They have lots of information on here. Unfortunately, when you Google or when you search for Charcot-Marie-Tooth, it doesn't come up with very much other than vincristine, which is reassuring because that has the most evidence that it's going to be a problem. But basically, you can go in and search for any medication that you think would possibly be okay. The other thing that they have is, and just incidentally, and I thought this was quite funny when I started writing this presentation, next week is Be Wise Medicines Week. So what a great time to take the opportunity to actually go and have a review of the medications that you're on and have a little bit of a think about things using the NPS website. They've got some really nice resources on here, including some questions, medicine-wise questions that you can ask your doctor about the medications that you're about to take. And you can also go in and search for medications, as I said. So I put in vincristine because I knew that ought to come up with a nice big juicy warning. And sure enough, you can see this is the only thing that actually mentions it by name. But here it is saying, if you're about to be given this medication, you should not take it if you suffer from this disease. The other one I put in, just to have a look-see, was Flagyl, which is one of the antibiotics that was listed on the American Association, in that paper, and also on the American Association site. And you can see very clearly in language that anybody should be able to digest, that it very clearly says that you really probably shouldn't take this medication if you've got some kind of disease of the nerves. So I think this should be information that any of you, as somebody who does not have huge amounts of medical background, should be able to digest. You should be able to go in and read this stuff yourself and then go back and discuss it with somebody if you need to. If the internet isn't accessible to you, or you feel like you need to talk to a real person, there is a medicines line that is linked to the NPS website, 1300 Medicine, and they should have people at the other end there that can address your questions. And I guess the other thing that I thought was really important for everyone to have access to is the adverse medicines events line. And I think it's really important that if you feel like you've been given a medication that, as well as that leads to worsening of your neuropathy, that as well as going back and talking to your prescribing doctor about it, that you actually get on the adverse medicines events line. Because unless these things are reported and collected, then nobody knows. other than by word of mouth. And so collecting this data can become really important for future medical decisions about medications. And just note that they're not open all of the time. You do need to be able to ring during sort of business hours. So there isn't a huge amount of concrete evidence that links drugs toxicity specifically to Charcot-Marie-Tooth, with vincristine being the exception. There are certainly some drugs on the not advised list, and if you read through that not advised list, the reason why is because they're known in some way to have pretty rare but still either problems with muscular damage or problems with nerve damage. Remember that many of the changes that you might be experiencing may actually just be due to the ageing process. Unfortunately, we can't stop getting old. It's just the way it is. And of course, what you're trying to do is manage those risks. And so you always need to be with your doctor managing that risk control. Peripheral neuropathy that declines a little bit may be a far better scenario than getting an aggressive cancer that's not being appropriately treated, or uncontrolled diabetes, or uncontrolled cardiovascular disease, or whatever it is. So make sure that you're an informed consumer and that you're working with somebody that you're confident to work with in a medical setting. And last but very not least, this is my little guy who actually ended up coming 7.5 weeks early, which was 2 weeks after I presented last year. So a little bit of a surprise. We're probably lucky he didn't arrive while I was standing here. And he actually turns 1 today, so I'll be spending the rest of the day having fun with him. And this other picture of a lady with a baby is, you may remember if you were here last year, that I was presenting on behalf of my PhD student Sue, who'd received a CMT grant. And I can now reveal the reason that she couldn't come is because she had really bad morning sickness and she just couldn't travel. So she's got a beautiful little boy now too. She's just come back after maternity leave and has really wanted me to express thanks to the Society for the money, and that she's really keen now that she's back to get in and use the equipment that she bought with the kind grant of the association. So that's all I really had to say today. I'm not going to be able to stay for question and answer this afternoon, and I'm not sure where we're up to in the time schedule, but I'm going to stay for lunch, and if anyone wants to come up and ask me or email me after the workshop, that's absolutely fine.
Thank you very much.